My name's Denise, and just before we head on into our slides, we just want to make you aware that slide 3 does show some live pictures of endometriosis. So we appreciate that's not to everybody's taste. So if you don't want to have a little look at it, then we will give you forewarning that it's coming up so you can turn away. So I'm going to hand over to Mr. Arshad and he will go through the slides with you. We're going to go, we are going to have the webinar as a family because it's great to have our masks off. So we are going to do this as a joint effort. So feel free to throw anything at us.
Thank you, Denise, and good evening, everybody. And it's a real privilege to be presenting to you. And it's based around questions that, you know, real patients and yourself wish us to answer. And I'm going to go into my first slide, really. Most of the bulk of the questions were really about what is endometriosis and adenomyosis and what's the difference and similarities between the two. So I know there's a lot of press on endometriosis. I'm going to start with adeno. Adenomyosis is essentially the womb lining or the endometrial stroma glands or tissue, which is penetrating deeper, invading the muscle wall of the uterus. So it's confined within the uterus. So that's where adeno and endo differ. Adeno is really confined to the uterus. And endometriosis is the same pathology, the endometrial stroma glands, endometrial lining, but that's found outside of the womb. So the similarities are that adenomyosis and endometriosis can, you know, cause pain, as you all know, and that's more cyclical pain to do with the menstrual cycle. Can also cause infertility, and we'll go into that. The difference is that adeno can cause heavier menstrual bleeding because it's within the womb, the lining of the womb, or within the wall of the muscle of the wall, whereas endo is outside of the womb, so it doesn't really contribute much to the heaviness of the menstrual bleeding. And there's also other differences. So the similarities again would be in the management as well. Adeno and endo, you'd be managing with medical management, such as contraceptions to suppress the ovaries and minimize the endometrial growth. And with adeno, you could also do a hysterectomy, whereas in endometriosis, because it's outside the womb, that's not that suitable. I'm just going to go further down this slide. So adeno, as you can see in this slide, right to the bottom on the right-hand side, you can see that adeno can be a focal deposit. And here it can affect implantation and fertility issues. And if this was to be drained, then you can also manage adenomyosis by drainage, and that can help patients with infertility issues. The other type of adenomyosis is the one in the middle on the right, where my cursor is, and that's diffuse adenomyosis. And as you can see, the adenomyosis is affecting the entire uterine cavity. So that would be more appropriate to be treated not with drainage, but with a Mirena coil if you're symptomatic, or possible hysterectomy may be consideration as well. Adeno and endometriosis share the same pathology, and we don't know the cause, but we think it's likely to be due to genetic, autoimmune, or mulariosis, which has been really made famous by Dr. David Redwine, sorry. So I'm just going to go into the slide on endometriosis. So if you're a bit squeamish, it's only going to be for a few seconds, but please turn away now. I've included this slide because a lot of my patients do ask to see what does endometriosis, the actual pathology that they suffer with, what does it actually look like? And as you can see here in the slide on the left, you can have it as a dark black spot, and that is endometriosis. And in the picture on the right, that is endometriosis again in the pouch of Douglas. And as you can appreciate, it is outside the uterus. So carrying out a hysterectomy won't cure those endometriotic deposits there, and is not the answer. So in endometriosis, the answer is either medical management or complete surgical excision of endometriosis. So endo and adeno can cause pain, infertility. Adeno differs, it can cause heavy menstrual bleeding, whereas endo doesn't necessarily have to. Now I'm going to move on to slide 4, which is our last slide, which is just a summary. So everyone who turned away can turn back now. So sort of in summary, between endo and adeno, they share the same pathology, just the location's different. Symptomology is more or less similar, pain and infertility, but adeno can cause heavier menstrual bleeding. And in terms of treatment, you can give medical management and excision of endo, but with adenomyosis, you might want to do adenomyomectomy or drainage of the adenomyosis or possible hysterectomy. That concludes sort of the first aspect of this talk. So I'm going to stop sharing my screen there. I'm going to hand over to Karen.
Hi, thank you, Ilyas. Hi, I'm Karen. I've been asked to join this webinar to give a small chat on hysteroscopy and actually what a hysteroscopy is and how it is useful for endometriosis and adenomyosis. So a hysteroscopy is a procedure that involves examining inside the uterus to either rule in or rule out any abnormal pathology in there or any abnormal findings. The way we would carry this out, we do the majority of our hysteroscopies in an outpatients department. So ladies can have this procedure done whilst they're awake. And what we use is a very small telescope that we pass through the cervix and into the womb. So we can identify whatever it is we think may be in there or what might not be in there. One of the questions that was asked, which is usually asked quite a lot, is it painful? Now, hysteroscopy is, as we know, all patients are individual. A lot of patients, whenever I am counselling anyone before I carry out the hysteroscopy, I will always explain to the patient that this may not hurt at all, this may be uncomfortable, or this may be too uncomfortable that we would need to stop the procedure. So all our patients are always given the choice of whether they want to go ahead and have it done as an outpatient. If they don't, then obviously we have other avenues that we can go down. But we do have a lot of pain relief within the department of the hysteroscopy department that we can use. It is all about patient's choice, and it's our individual care for patients. Now, the other question is what role it plays in adenomyosis and endometriosis. So the majority of the time, if ladies are referred to me for a hysteroscopy regarding usually adenomyosis, because as we know, endometriosis is outside the womb, so a hysteroscope would not pick that diagnosis up. But adenomyosis, we can sometimes see on the lining of the wall, as Ilyas shows in his slide, slight little small black or browny spots. It doesn't always pick it up, but it can be a good diagnosis tool to use. And one of the treatments for it is, as we've said, Mirena coil, and that can also be fitted at the same time as the hysteroscopy carries out. So you can do a see and treat appointment in that way, where it's all done in one go. So I will leave you open to any questions that you want to ask me about it, and come back to me shortly.
So
thank you.
Can I just ask,
Yes.
you know, the majority of the patients, are they quite comfortable whilst having the outpatient procedure?
Yes, the majority are comfortable. You may find it might be slightly uncomfortable, like a mild, but we do have Entonox on hand, which is the gas in air, if needed. And we do find that when we have our HCA in with us, they tend to release that anxiety from a patient if they do feel anxious, because sometimes it's patients' perception that it's going to be uncomfortable, and a lot of the time it's not. And it's also people picking up information from other people who might have found it uncomfortable, but as I say, it's very individual, and some ladies don't feel anything whilst just carrying out the procedure.
Yeah, and whilst it's true, in the outpatients, whoever's ordered or requested the test, they probably do counsel the patients
absolutely,
that
yeah,
the options of going for GA or ambulatory, being awake, and it's usually patient choice that they want to be awake, because it's quite convenient. But do you find that a lot of patients have taken sort of special pain relief that are useful? Yeah,
best guidelines for the RCOG and the BSGE is to take paracetamol and some ibuprofen, non-steroidals, an hour before. Not everyone can take non-steroidal, so we would advise them to take whatever real pain relief that works for them. And the evidence is that it's not as uncomfortable as it would be if not taken. Yeah, so that's all in the leaflet that's given to the patient before they come. information.
Perfect. And sometimes I add in, just to add in some buscopan as well, because antispasmodic can help with crampy uterine.
I would
pain.
I'd advocate that if the patient did find it uncomfortable, and when we say uncomfortable, we're talking like period-like type pains. So buscopan is definitely one of the first line choices that I would advocate for a patient if they did feel that spasmodic pain. And it usually relieves that pain within a few hours, if not less.
Excellent. Excellent. Thank you. Cool. Denise, do you want
to? So we could lead on now into the questions that have been put to us, if that's okay. We're okay for time. So is that okay for you, Emma, to go?
Yeah, that's fine. I can start.
Sorry, Emma, could I maybe, I think in the sort of I read somewhere that there were some questions on sort of research and the latest thing. I could talk a little bit more on that.
Yeah, definitely. Yeah, that'd be great.
Okay. I mean, currently the latest research in terms of endometriosis is really the biggest frustration, as I'm sure a lot of the viewers know, is the lead time for diagnosis, which we know is about 7 to 8 years. And that's because we're just very poor at putting two together, that cyclical pains due to endometriosis. But we aren't, and the sort of the diagnostic tool is a laparoscopy, but there's a lot of teams up and down the country looking at biomarkers, certainly here at Liverpool and Oxford, are looking at biomarkers and non-invasive tools to try and diagnose endometriosis. So there's a lot of work being done currently in that school with endometriosis. And in terms of latest research with adenomyosis, there's a lot of work being done in terms of diagnostic modality, imaging diagnostic modality. So a lot of work with MRI and power Doppler ultrasound and 3D ultrasound as well, trying to actually make us diagnose adenomyosis more than we were previously. So you might find that this is becoming more and more increasingly common to be diagnosed with endo and adenomyosis. And in some literature, some reports, you can have concomitant disease in about 25 to 49% of patients might have both endo and adenomyosis. So great. I just wanted to include those points for the viewers.
Fantastic. Thank you, Ilyas. So what I'll do is I'll go kind of back and forth between the pre-sent and then the live questions. So starting with the pre-sent questions, the first question I've got is, could adenomyosis make it difficult to conceive by preventing an embryo from implanting, or could it increase the risk of miscarriage?
Okay, so I'm going to answer that one for you. So yes, it does make it difficult to conceive, because particularly with anybody with diffuse adenomyosis, so it makes it very difficult for implantation. So that's, from that point of view, it is very difficult to conceive. Does it increase the risk of miscarriage? Yes, it does. Again, because of the diffuse effect of the adenomyosis. So yes, there is a portion of, percentage of women who will unfortunately suffer a miscarriage.
Yeah.
Thank you, Denise.
Carry on. No, there's a lot of work, especially in Europe, being undertaken to do hysteroscopy with ultrasound guidance to look specifically at adenomyosis. In my slide that I showed, you can have adenomyoma just behind the endometrial lining, which you can see causes implantation failure. So that's possible to be hysteroscopically drained and hopefully get rid of that as a cause of infertility. So that's really patient and doctor centered as to whether it is able to be drained and improve chance of fertility.
Thank you. And from the Q&A function, we've got, why can sorry, you're gonna hear me stumble across this word. I was like, Emma, you can do it. Adenomyosis. Why can it cause pain outside of your period too?
So usually endometriosis and adenomyosis, usually cause more pain during menses, and that's more commonly that we find it. Now, occasionally, so I would say that in majority of BSG centres that we'd say that endo and adeno are more likely to be a cyclical nature at the start of menses or premenstrual as well. Occasionally, when patients suffer with chronic pelvic pain due to causes such as endometriosis or adenomyosis, then they can develop other causes of pain, such as sensitization to pain. The nerves get more sensitive to pain, and that can be felt continuously. Sometimes they can get their pelvic floor muscles are, constantly being are going to spasm. And they can feel pelvic floor muscle spasm, and that can be another cause of, say, dyspareunia, which is what patients also suffer with. So directly I'll say endo and adeno usually cause cyclical pain. However, secondary effects can cause them to have other continuous pain, and then they might have other diagnoses as well. I mean, they might suffer with fibromyalgia, chronic fatigue syndrome, and other associated symptoms. So really, the diagnosis is really important, and to be listened to, and to for the clinician to spend time to listen if there's any other causes of pain, and to talk about it in more detail.
Thank you. Should it be routine to do an MRI before or after a diagnostic laparoscopy to ensure that adenomyosis isn't the cause for any continuous pain?
So yeah, it's interesting. I think we all agree that we should individualize the care of our patients and really listen to what our patient is suffering with, and really what we want to do is really improve their quality of life. In a non-invasive way, if possible, first line, and if that doesn't work and then we need to do surgery, then MRI is a guide really to help us understand whether organs such as the bowel or the bladder are involved. So if patients don't have bladder or bowel symptoms, then it's not necessary that they might not need an MRI. However, if they if during the consultation it is felt that on history bowel and bladder is involved, or possibly diaphragm, they get cyclical shoulder tip pain, and you think about diaphragmatic endometriosis, and or when you're doing a clinical examination and you do a pervaginal examination and you feel a nodule, you want to feel this patient maybe does have deep infiltrating endometriosis, then the MRI is there really to help us determine what we're thinking already. Is there rectal involvement? Is there bowel, or is there bladder involvement? Is there diaphragmatic involvement? And so, yeah, in those cases, then an MRI is helpful. And we've got to also remember that, MRI is helpful, but sometimes it can miss lesions, especially with diaphragmatic endometriosis. It's quite common that patient could have a good, shoulder tip pain with cyclical, but might not be seen on MRI. So we've got to really holistically manage the patient, and try our first line management, which would probably be medical management first.
Okay, thank you. And how common is it for someone to suffer from endometriosis post full / total hysterectomy?
Sorry, could you say that?
Oh, sorry. How common is it for someone to suffer from endometriosis post a full hysterectomy?
So
Interesting.
Just what we mentioned before with endometriosis is found outside the womb. So we would say that we want to completely excise the endometriosis, and we've got to bear in mind that endometriosis is an enigma of a disease where you can have it present and it might be the cause of pain, and it can be present and it might not be the cause of pain. So in a patient who does have endometriosis, first line wouldn't be a hysterectomy. It'd be medical management, and if that fails, then to do complete excision of the endometriosis. Now, if the patient had heavy menstrual bleeding and completed their family and they wanted a hysterectomy as well, because you're thinking they might have adenomyosis, then at that time you'd want to do a total laparoscopic or minimally invasive, if preferable, hysterectomy with complete excision of endometriosis, and then it's a case of whether that endo was the cause of the pain. If it was the cause of the pain, chances are that patient's going to be better. And the BSGE, they published a paper in the BMJ, in Open BMJ in 2016, which looked at all of the BSG accredited centres throughout the UK over a period, I think it was 5 years. And they found that on average, the pain score for a patient would go down by 6 out of 10. at 6 months. So it's really important that we continue auditing our figures, and BSG accredited centres do audit their figures, and we all contribute to that, and all the patients contribute to that as well. So when we have cases, we do questionnaires on our patients before surgery, after surgery, and follow them up for at least 2 years.
Are them figures just based, they're not just based on ladies who've just had hysterectomy, so are they based on ladies who've had excision of endometriosis as well?
Yeah, so
I think the question was just solely about a hysterectomy, was it? And
yeah,
I think
yeah. So
you guys will agree that it's not always helpful, is it, to just have a hysterectomy?
yeah, absolutely, absolutely. So I think 2 parts to your reply. I think with the patients that we really do the questionnaires are those patients not just with endometriosis, because the majority have mild and moderate endometriosis,
Yeah.
but those with more deep infiltrating endometriosis involved with pararectal dissection. So we really look at them tightly. But yeah, you're right. With endometriosis, we're not solely thinking about hysterectomy. With the sister condition, so to speak, with adenomyosis, then it may have more beneficial.
Which I think is a common theme, that people think if you remove the womb, the pain will go, and it doesn't, does it? Because as we know, it's outside the womb.
Absolutely.
Okay,
But
so-
good. Absolutely correct. Well, good point.
Thank you. And if you're found with endometriosis in the pelvic cavity during a diagnostic laparoscopy, are you immediately more likely to have adenomyosis too? And should that be investigated immediately too?
So it's a really good question again, searching question. I suppose, prior to surgery, you want to individualize the care for that patient, and you would be thinking, what is the patient's symptoms and how can I help them? Whilst it's true, endometriosis and adenoma, in the first part of the question, endo and adeno are concomitantly present in about 25 to 49%. That's from the literature. In terms of what would you need to look for adeno? Well, you'd be looking at what the patient's problem was, and prior to surgery, you'd probably be doing the relevant investigations that's led up to the surgery.
Thank you. So my next question is, how successful is the Mirena coil at keeping adeno? I'm just going to call it adeno.
Adeno.
That one.
Perfect.
Adeno.
That's how you call it. Adeno.
Yeah.
And
Adeno. So how successful is the Mirena coil at keeping adeno at bay if you had it fitted following extensive endometriosis excision surgery?
Again, that's very individual, to each lady that we see. Counselling about the Mirena is very important before insertion, because obviously the whole role of the Mirena is to shed the lining of the wound, so they're going to bleed. It has to bed in, so they may just get some cramping as well. So we like them to give them at least 3 to 6 months to see the effect of that. So if the lady has had heavy periods but they're still complaining, I've still got some pain here, then we can always back that up with a tablet as well. So yeah, I can only speak from our patients really, that it is very effective. It is a good treatment management. So
it's I think it's a good strategy. I think I agree. I think it's a great strategy because with endometriosis, you could also have adenomyosis. So by doing the surgery, you're treating the endo, but you might have some adeno that might not be picked up on scan. So the Mirena coil would, one, treat the adeno, maybe which was missed or undiagnosed, and also it'd help in minimizing recurrence of the endometriosis. By as everyone knows, is the estrogen, and you want to suppress the ovaries to minimize the estrogen. So inserting a Mirena coil, providing ladies, a lot of patients have heard scare stories regarding it, or just don't want it, don't feel it's right for them, and we respect that, and that's fine. But a lot of ladies do go for that strategy and are successful.
Yeah, I mean, in particular when covenant it's them in the outpatient setting, You do get a lot of positive feedback, you know, from them, and they do keep in touch with you, don't they, Karen?
They
And
do,
will
yeah.
ring you.
I think another one of our consultants here, Cara Williams, she deals a lot with adolescent ladies in Alder and then brings them over to carry on their care here when they get to 18. And a lot of them ladies who haven't been diagnosed with endometriosis because they're so young, but also obviously they're not going, when they're in pain, the last thing they're going to want is a uterus being removed. But a Mirena is a really good first line treatment to also help diagnose endometriosis, because if the pain settles, it can give a good indication that it could be down to endometriosis. Because really what we don't want to be doing a lot of surgical treatments on really young ladies. So it is a good diagnostic tool as well. And it does, I advocate Mirena coil personally. And I think we have a lot of female staff here, and I think they'll also back me up with that.
Oh, definitely.
From a personal point of view,
It's very effective. Yeah.
And I think, you know, we've all just gone through COVID and, you know, coming out the other end. But during COVID, when, you know, elective benign gynecology surgery was really difficult and not happening, then we would, you know, use all of our expertise in medical management, and the Mirena coil, a lot of people who might not have wanted it before did have it because they're having to wait such a long time for surgery, for different treatment, and we got good positive feedback from that. I think.
Yeah, it is. Yeah,
Didn't we?
yeah.
Definitely counselling is key, and you know, and being open and honest, it's key.
And if it's the key that you know, if it works and then you've prevented a diagnostic laparoscopy or laparoscopy, because at the end of the day, we've got to understand that, you know, laparoscopy is an invasive surgery, and some people do get complications from that, and not common, but you know, 3 to 8. I think we banned about 3 to 8 per 100,000 women may die from, you know, an injury that suffered at time of diagnostic laparoscopy. That's very rare, but you know, if a Mirena coil does prevent does work, then
obviously it's less invasive.
Yeah.
I think a lot behind the Mirena coil is a lot of ladies are reluctant because they feel like they have no follow-up with it. Once the Mirena coil, they're out in the big wide world and they don't like it, blah, blah, blah. So we've done some evidence, and what we do now is I will give my work contact number. So there's always some port of call for the patients to ring if they do have any problems, and I can reassure them or give them advice. Because when you first put Mirena coil in, you know, you can have bleeding and it can be a little bit painful, but there is things out there to help alleviate all that. And just having that knowledge and having somebody to speak to can take all that worry away. And it obviously, we know it is less invasive, and we sometimes don't need to go down a surgical point.
Thank you. Is endometriosis an autoimmune disease?
Oh, I like this question. Yeah, it's a good question.
Interesting.
It is an interesting question. Yeah, it's one of the top theories that it is, but we don't know, because there is still, you know, a lot of research going on to see whether it is or whether it isn't. So answer to that is we don't know, but it is, autoimmune is the top of the class for being, you know,
the likely contender.
Yeah, absolutely.
There are a lot of theories going around, and
Yeah.
it's definitely, you know, genetic, Milleriosis,
Yeah.
autoimmune is up there.
And hopefully in time we will find out, which would be good, probably.
Thank you. My next question is, how can I find a consultant near me who has an interest in or specializes in adeno? It's easy to find one for endometriosis, but not adeno.
I suppose, you
Would it
know,
not be both? Would you not be dual?
yeah,
On the
yeah,
BSGA and
yeah,
you know.
it's compartmentalizing it even further. But I mean, adeno and endo are similar pathologies. One's confined in the uterus and the other's outside of the uterus. And I think most endometriosis specialists would be specialists in adeno. It's really, I suppose, how you'd find out any information. You do your research, you'd ask your friends, your colleagues, you look up on the BSG websites or any other medical website that might do that. But you know, anyone who's really a specialist at endo would probably be a specialist in adeno as well.
Oh, okay, so if you go onto the BSGE website where it's listed the centres, you'll find the specialists, and the more often or not they're going to specialize in adeno too.
Yeah.
Fantastic, thank you. And fatigue and lethargy are a really large part of having endometriosis. Is the exact reason known for this correlation?
Oh, I'll answer this one as well, because I always have a lot of conversations with our patients regarding fatigue and lethargy. They all feel the same symptoms. Is it having a large part, you know, of endo? When you look at how endo affects your life, and I don't know, you know, you've got your heavy bleeding, you've got the pain, you're trying to, you know, run a home, have a life, and all that affects how you feel. So if you're not able to sleep, if you're not able to work, you know, you will become fatigued. If you're having heavy bleeding, then you're at risk of becoming anemic. Again, that will cause fatigue as well. If it is deemed that endometriosis is an autoimmune condition going forward in the future, then yeah, that would explain, you know, the fatigue and lethargy as well. But majority of our patients, when they phone through, that is the first thing they will ask: why am I so tired? Why am I so fatigued? And when you break it down, you think, oh yeah, I get that. You know, I'm not sleeping. I'm not eating very well. So yeah, so there are answers that I can give them, but for the course of it, then I can't answer that.
Yeah, I mean, that's a really good. It's like, you know, we can say there's some exclusive symptoms to endo and adeno, such as, you know, cyclical pelvic pain, cyclical bleeding, heavy bleeding. And then there's some non-exclusive symptoms, which are generic, like fatigue and tiredness, which can be open to chronic fatigue syndrome, fibromyalgia, you know, anemia, lots of other things. But certainly our endo patients do find that they are so they just caught up, you know, with their world, that they're suffering in so much pain. They don't sleep well. They've got pressures of, they've got young children, they want to perform well, play with their children. They've got husbands, they've got partners, that they want to live a full life. And then they're not getting much sleep, they're not getting much rest, and it just catches up with them occasionally, and they feel fatigued. And that's also something that we're trying to increase awareness in the workplace, because, you know, a lot of our patients will have times when they're off work because of precisely these reasons. And I think Denise is going to talk a bit more about the employment friendly endometriosis.
And the police.
So what we've from the last conference, Worcester became the first NHS employer friendly for the scheme. So, and Merseyside Police as well. So we've been in touch with Merseyside Police who got that through, and we're just waiting now for the final hurdle for us, and then we're going to become an employer friendly scheme, because an awful lot of our staff, relatives, either they know someone with endometriosis or they've got endometriosis, and we just want to reduce the length of time that is put down as sickness. That could be, you know, we could be work with them to have flexible work and have loo days, you know, condensed hours, you know, work with our staff to reduce those sick days. And we just think, you know, we're encouraging you know, everyone to get out there and become an employer friendly, because it's so important. So yeah, so we're quite proud of that, because it has a massive impact. And even with the partners, they're the ones that are supporting these ladies, and it's hard for them as well. They don't want to go asleep, or they don't want to have some nice time out while the partner is wherever and they're suffering. You know, they need to spend time with the kids, you know, they need to spend time with the kids, whatever. It impacts on everybody. So yeah, so that's a scheme that I advocate. I just love it. I just think it's you know, it's a great idea, and we all should be getting on board, not just hospitals. It should be, you know, in other workplaces, because it's so important for our ladies to, you know, rest, and to we need to be compassionate in what their needs are.
Thank you, Denise. And for those who don't know about it, so the endometriosis friendly employer scheme, so that's something that your organizations can opt into, and then they get training on how to create a endo-friendly workplace. And it's like we work with organizations to find out, well, what kind of tailor the support that their staff needs. So if you are interested, you can go to our website and have a look. So thank you, Denise, so much for dropping that in.
No, please do.
Yeah. Okay, so my next question, so this is from someone has stage 4 endometriosis, and so they've said they've got it in the pelvis, the bladder, the bowel, rectum, diaphragm, and also has adeno and pelvic floor dysfunction, and they want to know, they really want stoma bags due to how debilitating it is, and they want to know if they can elect this.
Sorry,
Stoma bags, elective.
Was
it elect
Sorry,
to
sorry.
have a stoma?
Yeah, yeah,
Was the pain?
yes.
so sorry. Go.
No, I don't know the answer.
No, I mean, I think it's really difficult to answer that question. In the time that we've got, obviously that's a real patient who's suffering really badly with really widespread endometriosis that is florid, tricompartmental disease, rectal, uterine, bladder, diaphragmatic. So it's affecting so much, and that would require a lot of individualized care within a big team, a multidisciplinary team approach, and really the skill of the patient and the clinicians would be in understanding the nature of the disease, where the disease is affecting that patient the most, and what they can do to try and alleviate and improve that patient's quality of life, and manage that patient and their life. And if it involves a stoma and the patient's happy with it, then that would be something that would be something that could be employed. But again, that needs a lot of that's not something that we could talk about here. But yeah, I think it's anything's possible.
Yeah, there's no reason why they can't have a good quality life after stoma, because they have all sorts of equipment now, nice bags and nice plugs that they can use to go swimming and so forth. So I'm sure the person who was having this is getting good support from their endo nurse, from their colorectal nurse, and their big team, to point them in the right direction and signpost them as to what available is to them, and hopefully they'll go on and have a good quality of life afterwards.
Thank you. Is there any evidence for the effect of progesterone, progesterone only pill versus IUDs for reducing endometriosis and adeno related pain?
Again, that's a very individualized.
I don't think there is there?
No, because some ladies, again, if they have the IUD inserted, and they, and like we said before, if they're happy with it and they can go, go and do whatever they have to do. There's some ladies that, need a backup with having a coil, for a small tablet with small amounts of progesterone only pill, to back that up if they've got any breakthrough bleeding. And then you've got your cohort of ladies that are quite happy, with the progesterone only. So again, it's very, very individualized what works for them, and with the side effects.
Absolutely. I think that's like, as you say, that you've got all these in your armory. You've got your progesterone pill, you've got your Mirena coil, and you've got your patient, and every patient's individualized. Some patients just don't, although you're screaming out and thinking, oh, Mirena coil would suit you really well. The patient just doesn't want it because they don't want it for an object in the body. And that's a waste of time going down that route because the patient's not buying into it. So, you would then go for maybe, if a tablet is acceptable, then you go for that. So it's good to have these all these medications up our sleeves. And so sorry. It's we've also got those groups of ladies that they can't have any type of progesterone, so that makes it a bit more challenging in how we manage their care. So yeah, so it's a difficult one.
but it's very individual. So we go, again, it's all holistic. We treat them holistic.
I think sometimes it feels like we're answering these questions and we're sitting on the fence, but I don't suppose we can shout any louder that it is individual care. And I know we've said it so many times, but everybody is different. We're not all the same. We don't all react the same to
One size doesn't fit all. So,
it's about listening to your patients, and as we mentioned, sometimes it's treating their endo, treating their adeno, treating their pelvic floor spasm, treating their chronic fatigue syndrome, you know, being aware of all these tools that we have to help our patients. Really, sometimes, you know, we have a pain management education program as well. So when, you know, most of our patients do get better, you know, with medical management or surgical management, but occasionally there are a few that might still have pain despite what we've done, and you know, maybe that the endo wasn't the cause of pain or so, but then we have a bigger team. We've got a psychologist, we've got a pain specialist, we've got physiotherapists, we've got bigger team that we can help manage that patient's pain and live a fulfilled life as well, and you know, do our best to make that happen. So there's lots of different techniques that we've got up our sleeves.
Fantastic. And if you if someone was attending another center and they were experiencing pain and the medication wasn't working and they weren't being referred to like the kind of multidisciplinary team that you have, could they request it, or is it due to the resources that a center has? Or what can they do after that if they're still experiencing pain but they're not being kind of
opinion? We're talking like a second opinion.
Yeah, so you kind of said after, if they're still experiencing pain after the medication that you've given them or the treatment you've given them, then they go on to another team where you can, like a psychologist or someone else. But if they're at another center and they don't have those resources, or they're not being suggested, what can they do to get those resources?
Usually it's that team that can refer them over to another pain management team, or the GP can do that as well. But usually if you've got an endo team and they haven't got those services, then they would refer on to a pain specialist.
Oh, amazing. Thank you. So my next question is, there's been several articles in the media recently about hysteroscopies and the pain they cause for some. Is there anything to suggest which women might suffer with severe pain from a hysteroscopy? And they've kind of they've put such as like vaginal birth, pain during smear tests, etc.
Again, Emma, individual. So I'd want to say yes, there probably are some ladies where you would think this might be uncomfortable. So I'll give you an example of like postmenopausal ladies who can be obviously lacking in a lot of estrogen, can have a lot of vaginal dryness. They might find it more painful using a speculum to do a hysteroscopy. So you would possibly change your approach and do what's called a non-touch hysteroscopy, which is now best practice anyway to do that, where you don't actually use a speculum and you go in with the telescope into the vagina and you visually do it through the cervix. So that can relieve pain in ladies who are postmenopausal. Ladies with endometriosis, I tend to find that sometimes they do find it a bit more uncomfortable. So I will always offer a anesthetic instiller gel, which can soothe, which can help numb the area and also help insert in the telescope. This does work well for ladies with endometriosis. We also use...
And you also use really thin telescopes, don't you?
Yeah, we always use thin telescope.
2.9 millimeters. So
oh,
really
2 millimeters.
2 millimeters. So
Yeah.
Really thin, small, no touch technique.
Yeah.
You've got lots of things. You've got edge locks, you've got cervical blocks, good music.
I think
distraction.
A lot of it. So, I'm not saying hysteroscopies are pain-free. Some ladies they are, but not always. But we do, I feel like if you do a good counsel, you explain to the patient what you've actually got on hand to help to alleviate any pain. And also, I tell every single patient, if you want me to stop at any point, you say stop. You are in charge of how far I am going to go with this procedure. And that will just alleviate patients' anxiety straight away. I've had a lot of feedback from patients saying what they thought was going to be a really difficult procedure. It really wasn't. It was managed really well. And it's all about how you manage your patient. No denying that no matter what you do, sometimes you might get a patient that is still in pain and you would just stop the procedure anyway. Even if they said, no, carry on, I would make the decision to stop, because we're not here to put people in pain at all. And we don't want any patients to be martyrs either, you know, because we will always do what's best for our patients. That's all I'm trying to say. And pain is one of the things which we will hopefully alleviate at any point of doing that procedure, because that is the biggest anxiety that most patients have, which is understandable.
I think also when you're talking about ladies who've experienced difficult smears, it's looking at what is the cause behind that, because it might not be anything physiological. It could be being a trauma, you know, in life that's exacerbated that. So right away, even in the clinical setting, if you're assessing your patient, you're thinking, what is the best route that we can plan for this lady to have the best experience with the least amount of discomfort. So it's very important.
And if the lady's not happy at all, then, you know, straight for GA, general anesthesia, under sedation. You know, now it's even safer with sedation, where they're in a deep sleep, they don't feel any discomfort, and you can do that. So
because that's their choice. If the patient chooses to not have it as an outpatient, then that's absolutely fine. We go with what the patient's choice is. Yeah.
Thank you. Does menopause make a difference to adeno?
So generally, you know, endometriosis and adenomyosis, there's a lot we don't know, and there's things that we do know, and we know they're estrogen dependent. So you know, when you do go through the menopause, then the estrogen levels do drastically decrease, and so you do get adeno and endo symptoms being relieved. You know, I know there is a cohort of women who do suffer with it postmenopausally, but the majority, when they approach the menopause, then the adeno and the endo symptoms do decrease.
And if they go on to have HRT, it's important that you get that right balance so it doesn't flare it up. So that's why we always, you know, it's combined effect, isn't it?
Yeah, give both the estrogen and the progesterone to counteract one another.
Okay. So it said that there's no cure for endometriosis, only treatment. Does that mean it can grow again after it's been cut out in surgery?
Yeah, so with this word cure, we were thinking about
we don't like that word. It's like a management, you know, manage the condition.
So I suppose with endometriosis, essentially what you're looking for surgically is complete excision, and that's the real key, is to completely excise all the endometriosis. And then the strategy with the Mirena coil, or whatever strategy it be, whether it be combined pill, progesterone pill, would be to try and minimize recurrence by suppressing the ovaries, by suppressing the estrogen that's there. But, you know, because sometimes you get endometriosis which might be microscopic and so it can't be seen. But as long as you've taken out what you can see, then you've got more or less you're good stead that patient will be pain free. Well, you know, will have their pain drastically reduced, where it's not uncomfortable, where they can manage and live a good life, good quality of life. So it's about suppressing it until they hit the menopause, and then it's naturally suppressed, the estrogen.
Difficult, isn't it? Especially if you've got ladies that you've done excisions on, and they want to conceive, so they're not particularly keen to have any form of hormone treatment after that, because their aim is to conceive. So I think usually with those group of ladies, that they're fully aware that, you know, your pain might decrease, but it won't always go away, because the aim is to have a baby. And so how you manage that is important afterwards.
So you try and do your best with surgical cure, or not cure, but, you know, surgically excises all that you can to reduce that pain, improve the chance of fertility as well, and reduce the risk of recurrence. But there is a risk of recurrence.
Yeah.
Thank you. And is there anything someone can do to reverse or stop the growth of endometriosis?
Yes, so there is a MRI evidence, a study done, I think, in France, where they looked at the progression and regression and stabilization of endometriosis in patients who were non-surgically managed. So they had MRI done and they were treated. Some cohort were not treated, some cohort were treated with medical management. And they found that with medical management, that actually stabilized the disease and actually regressed the disease. So going on hormones actually is a treatment of endometriosis. It has the potential of regressing the endometriosis.
Thank you. And this might be a person-to-person question, but hopefully I'll just ask it anyways. So is there a set time for endometriosis to come back after a laparoscopy surgery?
No, again, it's very individual, isn't it? You know, as to and what stage, you know.
Yeah, there's so much. There's a lot of variation.
That's a difficult question. That's a good question.
It's you know, the variability is, you know, in patients you might see it, you might not. There may be a heterogeneity in the skill set of the surgical team as well. So, you know, it all depends on the quality of the surgery and also the endometriosis where it is. Sometimes, you know, with endometriosis, it's not about, you know, it's about looking at the individual, and you want to do as much complete excision as you can, but you also want to retain the functionality for the patient. So what I mean by that is that endometriosis can be present, say, for example, on both uterosacral ligaments, and just very close to uterosacral ligaments are the hypogastric nerves, which innervate the bowel, the rectum, the vagina, the bladder. So if you go in hard and go in with a mindset that I really have to excise everything, you know, then you might actually cause damage to the functionality of that patient's bowel, bladder, and sexual organs. So you might cause more harm to that patient by giving them a lot of constipation or bladder issues and stuff. So what you want to do is really understand the disease and possibly go hard on one side and cause minimal, you know, and go slightly easier so you retain the functionality. So you want to excise as much endo, but you don't want to go to that point where you're now damaging nerves on both sides and you cause such bad functionality for that patient post-op in, you know, that mindset. So it's really about understanding the disease, doing what's best for the patient, trying your best to explain that to the patient as well.
Thank you. And what's the link between IBS and adeno?
Is there I didn't think there was. Is there one?
Well, you know, I think it's really about you know, there's a lot of it has similar, you know, endometriosis and stuff can affect the rectum, and can cause symptoms such as bloating and so may get confused with being irritable bowel syndrome as well. Yeah, you know, endometriosis can affect the bowel. Adenomyosis not so much, because adenomyosis is confined to the uterus, but endometriosis affecting the rectum can cause symptoms such as it flares up on the menses, so it can cause increased frequency of passing stool on a period that the patients notice, might cause bloating, because it might cause paralysis or ileus of the bowel during the menses as well, so it might cause bloating. So these symptoms might be similar to patients who've got inflammatory bowel or irritable bowel as well, so it might cause a diagnostic conundrum depending on where that patient was to go. If they went to a gastroenterologist or so, they might say, you know, you've got irritable bowel syndrome. But, you know, coming to an endometriosis person who sees that cyclical nature might be thinking more about rectal endometriosis. And again, a patient might have an overlay. They might have both endometriosis and irritable bowel as well. You know, so we always do talk about lifestyle changes as well, and think about, you know, changing one's diet, gluten-free diet, or avoidance of cow dairy products or red meat. Now, although there's no randomized controlled trial that says one trumps the other, but anecdotally, a lot of our patients,
it works.
it doesn't work in everyone, but it does work in some patients.